Hello everyone. The purpose of this video is to go over MKSAPs, endocrine, and diabetes, endocrinology and diabetes. I am aware that this is the pulmonary critical care one, but I actually already went through the diabetes one, and I have just gathered up some things that I think will be useful to any resident who just doesn't have time to go over all the questions. It's just stuff that you probably don't know because there's a lot of stuff you already know because you're a resident. Um, or if you are super duper advanced step 2 CK kiddo and you want to know like what MKSAP says about endocrinology and diabetes, or if you are like an advanced step 3 kiddo and you want to know what MKSAP says about endocrinology and diabetes. This is the MKSAP 17 book. I actually went over like through a PDF from the MKSAP 19 and I have written down stuff I've gotten wrong. The purpose of this video is I have no slides. It's just me reading out things to you so you can put me on a side and listen to me, or I don't know, or maybe I will just listen to this for the future for myself. But here it goes. I think I have a 30-minute time limit, so I think this is just going to be two parts. One is going to be 30 minutes long, the other might be just 10 minutes long. But okay, so things that you need to know. First thing that you need to know is that when you have an old person and you are increasing levothyroxine dosing, if they're like hypothyroid and they're on levothyroxine, cautiously increase or start levothyroxine dosing because they're very sensitive to increasing thyroid hormone. So if they're at 50, increase them to 60. Don't go from 50 to like 80 or 100. So cautiously increase levothyroxine in old people and start them at a lower levothyroxine dose. Usually for a normal person, if I go and I am hypothyroid, they'll start me on 2 micrograms per kg lean body mass. For an old person, you're a little bit cautious, so start that person on 1.6 micrograms per kg per lean body mass. So be cautious. First point. Second point, opioids inhibit the HPA axis. You guys probably already know this. It inhibits GnRH function, which will decrease FSH-LH, which will decrease testosterone, estrogen, and everything else. And then also opioids increase prolactin, and prolactin itself, again, will decrease GnRH, so it'll just mess up the entire thing. Just know that. The third thing is SGLT2 inhibitor contraindications. Everyone knows active diabetic foot and previous amputations. Another one that you need to know is severe peripheral neuropathy and then peripheral vascular disease. Both of these are contraindications to SGLT2 usage. Okay, for what to do about adrenal incidentallomas, if you see an adrenal incidentalloma in a question or whatever, you are asking yourself two things. First of all, is it excreting hormone? And second of all, is it benign or malignant? So for excess hormone, you're going to do the entire hormone panel. You're going to screen for biochemical hypercortisolism, even if they don't have signs and symptoms of hypercortisolism. And then you're going to screen for a pheochromocytoma as well. Benign adrenal incidentallomas are usually less than 4 centimeters. They usually have a lot of fat and lipid in them. Therefore, there are less than 10 house field units on a CT. And then their contrast washout time, they wash out contrast very quickly. They don't really hold on to contrast. So they have greater than 60% contrast washout after 10 minutes. When do you do an adrenalectomy then? You do an adrenalectomy if it's greater than 4 centimeters, if it's greater than 10 house field units, or if there is less than 60% washout at 10 minutes, or if the rate of growth of the mass is greater than 1 centimeter every year. So that's when you just take it out. For testosterone replacement therapy, the adverse effects of testosterone replacement therapy are erythrocytosis. Everyone knows that. Sleep apnea, hypertension, weight gain, sodium retention, lipid issues, and acne. So the things that people forget in this is weight gain, sodium retention, lipid issues, and acne. And for this is you want to check the hemoglobin. If someone's on testosterone replacement therapy, you want to check the hemoglobin every 3 months for the first year. So 4 times in the first year, and then every 6 months, so biannually, moving forward, and you want to maintain their testosterone in the normal range, the 320 to 800 nanograms per deciliter. Another point is for PCOS, remember Rotterdam's criteria. PCOS is a hyperandrogenic state, and LH and FSH like ratio is reversed. It's 2 to 1. The point is suspect something else when the following happens. If there is rapid hypervirilization, it might not be PCOS. If DHEAS is greater than 700 nanograms per deciliter, suspect an adrenal source because the adrenals make DHEAS. So suspect that this is the adrenals, like there's an adrenal, like an adenoma or something. And if testosterone in females is above 150 nanograms per deciliter, this is just too high for PCOS. Suspect that there's an ovarian cause, so get a pelvic ultrasound and then a pelvic MRI if the ultrasound is not conclusive. Then another thing is long-term estrogen therapy, be that oral contraceptive pills or be that over-the-counter OCPs, or like the emergency contraceptive pills. Long-term therapy with those will cause hyperprolactinemia, and hyperprolactinemia will result in like osteoporosis and all these other things. So you monitor prolactin levels. Mildly elevated prolactins of 25, 30, 60 kind of are normal with prolonged estrogen therapy. So this is a big reason, like primary care will see a hyperlactin, will see that there's no antipsychotic drug, and will refer them to endocrinology. Endocrinology will do nothing because they're taking like OCPs. Then another thing is whenever you mess with the pituitary on someone, a triphasic responsible upper, like surgery or trauma or whatever, first of all, they will develop a central diabetes insipidus. So their pituitary will be like, I ain't secreting any ADH. Then they will have a SI-ADH, will secrete a shit ton of ADH, and then they'll come back to normal. Then they'll go to permanent diabetes insipidus. So central diabetes insipidus, SIADH, and then permanent diabetes insipidus. I just want to focus in on that SIADH. Whenever you fuck with the posterior pituitary, there's a chance of them developing SIADH. So like how we mess with it generally is surgery. So surgery 4 to 12 days after surgery, and the peak incidence is 7 to 8 days after surgery. So 1 week after surgery, they're going to get SI-ADH. And when they get SI-ADH, that is because you manipulated the posterior pituitary. There's a lot of ADH around. So you will get hyponatremia because there's a lot of water relative to the sodium. So how you treat this is you recognize the symptoms early, you test for it, and then you give fluid restriction, hypertonic steroid and vasopressin antagonists. Moving forward. After pituitary surgery, another thing is we said that within 1 week, the incidence of SIADH is like really high. And then within a few weeks to a few months is the incidence of hypothyroidism is pretty high. Why? Because levothyroxine has a long half-life and it kind of presents later. So just keep that in mind. Then another thing about B12, everyone knows that like metformin causes B12 deficiency. I just wanted to point out that on 5 years of metformin therapy, the incidence of B12 deficiency is 20%. So after 5 years of metformin, 1 in 5 patients will have B12 deficiency. So 20% of patients will have B12 deficiencies after 5 years of metformin therapy. Then another thing I wanted to point out is if I told you that you have a bone scan, someone went in for some bone scan, and they have widespread areas of focal uptake on a whole body scan. Just think about that for a second. That sounds a lot like cancer. So there are widespread areas of focal uptake. That sounds like osteoblastic lesions. That sounds like cancer, which is pretty scary. So one differential diagnosis is cancer. Another differential diagnosis that you're going to keep, up there is osteomalacia. What is osteomalacia? Osteomalacia is a disease of vitamin D deficiency that leads to a decrease in bone mineral density. So there is no vitamin D, there's low calcium, low phosphate, and it can be seen in people like for random reasons, for gastric bypass or whatever. And what happens is when you bone scan those patients, it turns out that they have widespread areas of focal uptake, which kind of looks a lot like cancer. So just know that this finding is not always cancer. It can be vitamin D deficiency and osteomalacia. How you differentiate this is you can do 2 things. First of all, you can check serum calcium. If calcium is low, it is likely vitamin D deficiency. And we know that cancer generally causes a hypercalcemia. So hypercalcemia with this like picture, widespread focal uptake, that's cancer. Hypocalcemia with this picture, widespread focal uptake, that's probably vitamin D deficiency. And the second thing we can do is we can get a CT or MRI of like the focal uptake lesion, and then the radiologist will tell us whether it's cancer or like osteomalacia. So I just thought that was cool. Another thing, wait, did I skip one? Oh, no, I didn't skip anything. Another thing is medication-induced hyperprolactinemia. From 90% of patients on antipsychotics will have medication-induced hyperprolactinemia. Mostly, the prolactin level will be between 25 to 100 nanograms per milliliter. Some medications can increase it above 25 to 100. Those are risperidone, metoclopramide, and thiazines. They can bump it up to 200 nanograms per deciliter or milliliter. So between 25 to 200 is medication-induced. Anything above that, now start suspecting micro, macroadenoma, all that stuff. Long-term medication-induced hyperprolactinemia is a problem. Why? Because prolactin inhibits GnRH, which inhibits FSH-LH, which inhibits estrogen, which causes osteoporosis. How we treat this entire problem is they need to be on an antipsychotic because they're psychotic, so we give them estrogen. Remember, we need to rule out medication-induced hyperprolactinemia. Why? Because if we think that it's like a true hyperprolactinemia and we give them cabergoline, which is a dopamine agonist, and if they're on and they're already on an antipsychotic and they're actually psychotic, like if we give cabergoline to a psychotic patient who's on an antipsychotic, we will precipitate further psychosis. So we need to really rule out medication-induced hyperprolactinemia. Then another thing that I wanted to point out is if we give anabolic bone resorptive therapy, what that generally means is we're giving teriparatide or abaloparatide. What that means is that's recombinant PTH. Once we stop these medications, this teriparatide, abaloparatide, we need. So how do these medications work? The PTH has bone resorptive effect and anabolic effect as well, and these medications have resorptive and anabolic effects as well. Generally, they anabolize more than they resorb, but when we stop the medications, the resorptive effect persists. What I'm trying to say is that you need, when you stop these medications, teriparatide or abaloparatide, you need to start a bisphosphonate denosumab ASAP within 1 month of completion of those therapies, or the bone density will plummet. And then also remember that there's the theoretical risk of osteosarcoma with these medications. Then another point about bones is if someone is on bisphosphonate therapy for 3 to 5 years and they ask you how do you monitor therapy, everyone is going to choose DEXA. You're not going to choose DEXA. The reason you're not going to choose DEXA and T-scores is that sometimes you can have prolonged bisphosphonate therapies and we will repeat the DEXA and your DEXA will be the exact same. Your T-score will be the exact same. The reason for this is as follows. DEXA may stay the same or even decrease further. Why? Because some sites of cortical bone will have decreased mineralization. In some areas, you will have laid down new bone, and that will be hypermineralized, and that will lead to a false, like a low T-score. And then sometimes there's a transient increase in porosity of cortical bone. However, just because the T-score has lowered doesn't mean that the bone density has decreased and this is failure of therapy and whatever. The bone actually has gotten stronger. Like the studies show that the bone has gotten stronger. So don't use DEXA to monitor responsive therapies. Yeah, get a DEXA, look at the T-score, but if it's decreased, don't be like, oh shit, this didn't work. It's just that DEXA is like a bad tool to monitor this. And also just on top of this, like what we use instead is we look at the same bone. So if we looked at the humerus head or something, we look at that same bone and see how that's done. We make them go to the same testing center because machine to machine variation in T-scores also exists. And we look at gram per centimeter square density there. That's kind of what we look at if we have to use something. So they go to the same facility to get the DEXA. We look at the same bone we looked at last time. So right hip. And then we look at gram per centimeter square. The next point I wanted to make is for hypoparathyroidism, obviously they're going to have low calcium and we're going to try to keep their calcium in the normal range. We're going to give them a lot of calcium vitamin D supplementation and we're going to give them thiazide diuretics. One thing we're going to monitor is serum calcium. The other thing we're going to monitor in hypoparathyroidism is the urine calcium. Because if the urine calcium starts to rise above 400, 500, 600, that means we got to tone down giving them oral calcium or else they're going to have a stone. So monitor urine calcium in hypoparathyroidism, and that is the generally thing. High urine calcium will limit your therapy. And then also in these patients, we give them, even though they don't have parathyroid hormone, so you'd expect us giving them 125 OH vitamin D. No, we just give them normal vitamin D, and we hope that that works. If that doesn't work, if like 1,000 to 4,000 international units per day of vitamin D doesn't work, we add 125 vitamin D. But generally, we just give them the normal vitamin D and hope it works. Just another point I wanted to make is instances we measure ionized calcium. We measure it in cirrhosis because your protein is all messed up, in malignancy, in cachexia, and in acid-base disorders. Okay. For mixed edema, okay, another point I wanted to make, mixed edema coma. So if suspect mixed edema coma in anyone who has hyperthyroidism and now has altered mental status, I will read out signs and symptoms of mixed edema coma and then I'll make 2 points. Signs and symptoms of mixed edema coma: psychosis, coma, hypothermia, bradycardia, hypotension, hypoxia, hypercapnia. So what are you going to do when you see mixed edema coma or you suspect mixed edema coma? First of all, you're going to examine the neck. If they have a thyroidectomy scar, that's it. It's probably mixed edema coma. How you're going to treat is you're going to load them up. So they're going to be like, the point I wanted to make this is they're going to have a very low body temperature. Do not choose the option that says active cooling or active warming process. Why? Because if you have mixed edema coma and you're hypotensive and I actively warm you, your skin vessels are going to vasodilate and you're going to go further hypotensive. So instead choose the option which is like load this guy up on thyroid hormone right now. So give a 200 to 400 microgram loading dose of levothyroxine and then go 1.6 micrograms per kg per lean body mass per day to like replenish like stores or whatever. So like choose the option that says give thyroid hormone now. Don't freak out and see a low temperature and like actively warm these people. And generally avoid stress dose steroids. We generally give stress dose steroids to these people, but you don't really have to give it. And another point I wanted to make is inpatient. if a person's admitted to the ward, what's the inpatient glucose target? Generally, inpatient glucose target is not like the normal glucose target. We generally target 140 to 180 milligrams per deciliter. The reason we do this because like hypoglycemia is much more dangerous than hyperglycemia in the inpatient settings. And there is this trial called the NICE sugar, the NICE sugar trial, which showed that there's a better mortality if we have higher glucose targets. If you're okay with the 140 to 180. Then another thing is markers of bone turnover. Just know what these are. They're markers of cross-link. Whenever collagen is cross-linked in your body releases these markers, and those are C-telopeptide and N-telopeptide. There's limited evidence to like look at these markers for osteoporosis. We don't really use them to monitor anything, and these markers are increased in fractures anyway. So if a guy comes, he's fractured his thing, and they tell you that these markers are high, that's normal. We expect them to be high because bone is being laid down. Another point I want to make is hypo and hyperthyroidism. Generally, patients with hypo and hyperthyroidism complain of hair loss. I will tell you that any woman above the age of 20 will complain of hair loss. So generally, these patients are taking biotin and other supplements over the counter. The thing about biotin is that biotin messes with TFT testing, thyroid function testing, and we have to tell patients that you have to be off biotin for at least 1 week before you go for TFT testing, because biotin messes up with that test. Specifically, if they're taking biotin, it will mimic a thyrotoxicosis picture. It will mimic like they'll look like they have higher thyroid hormone levels than they actually really have. So stop biotin. Some places say 2 to 5 days. Some places say 1 week. In the clinic I work at, we just tell people to stop it like 3 weeks before because people don't remember. Differentiated thyroid cancer, the examples are papillary and follicular, and remember that we want TSH to be suppressed, so we have a very, very low TSH and a high normal to a high T4, and that is okay for these patients. In primary care, if you see this, check their chart, ask them if they've ever had thyroid cancer or something removed. If they have, please do not decrease levothyroxine dosing. This is like a common mistake. Next thing is, zoledronic acid, which is an IV bisphosphonate. We give it as an infusion. The most common adverse effects are this flu-like infusion site reaction. As soon as they get infused, like they feel sick and whatever, this generally gets better with repeated infusions of zoledronic acid. We pre-treat with antipyretics because we think it's interleukin-1 and like TNF-alpha mediated. And then zoledronic acid is contraindicated in a GFR less than 35. And then the next thing is another adverse effects other than the infusion site reaction is hypocalcemia. Another thing is I wanted to point out is that if you have hyperglycemia in pregnancy, if you have it if you are meeting the criteria for DM type 2 in the second and third trimester, you have gestational diabetes mellitus. If someone comes in and they're in their first trimester, if they're in their 4th week and somehow you've done an OGTT and they have hyperglycemia and whatever, if they have it in the first week, that is diabetes mellitus type 2. In the first week, if you're meeting the diabetes the cutoff, you have diabetes. In the second and third trimester, you have gestational diabetes mellitus. Gestational diabetes mellitus is a disease of the second and third trimester. If you have a disease in the first trimester, you have diabetes, bro. You don't have gestational diabetes. It's not the pregnancy, it's you. That is why we screen for gestational diabetes mellitus at the 24th to the 28th week, and then after pregnancy, and yada, yada, yada. Then another thing I wanted to point out is if someone has a multinodular goiter, like an autonomous nodule, and they go for a CT angiography or they go for any CT contrast study. Contrast has a lot of iodine. That goiter is going to take up the iodine, and they're going to go into thyroid storm or thyrotoxicosis. So just keep that in mind. That's just something that can kind of slip our minds. So they'll say a patient with a past medical history of multinodular goiter, yada, 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 and later on they're going to be going for some procedure, and they're going to be all sick after the procedure, and you have to put 2 and 2 together that thyroid nodules, probable multinodular goiter, probably they're having thyrotoxicosis from the contrast. The other thing I want you to point out is hyperthyroidism, indications for surgery in hyperthyroidism. Everyone always forgets these, so I'm just going to repeat them. Age less than 50, serum calcium greater than 1, the upper limit of normal, GFR less than 60, 24-hour urine calcium greater than 400 milligrams per deciliter, nephrolithiasis, or nephrocalcinosis. This is the one I like a lot. Nephrocalcinosis is also an indication. Mostly whenever you have hypercalcemia, you have hypercalciuria. So your body sees that I have high calcium and it pees out that calcium. There are 3 instances in medicine where you have normal calcium in the urine. That is milk alkali syndrome, thiazide use because your body's reabsorbing it, and familiar hypercalcemic hypocalciuria. That is why the disorder is named as such, because it's super weird to have hypercalcemia and hypocalciuria. And these are the three instances in medicine where you're going to have that. And then also know, okay, everyone knows diabetes type 1, diabetes type 2, yada, 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 whatever. Know that there are other types of diabetes as well. I'm just going to take a few names. Ketosis-prone diabetes, ketosis-prone type 2 diabetes, flatbush diabetes, idiopathic type 1 diabetes, atypical diabetes. Like, there are a bunch of types of diabetes, guys. Like, I didn't know that. And then it's type 3 diabetes, which is like if we take out your pancreas and you get diabetic, you are now type 3 diabetic. But this is just like fancy shit. Then know that for generally, if they have CKD and they have diabetes mellitus type 2, that really limits the amount of drugs that you can give them. For metformin specifically, do not start if GFR is less than 40 and discontinue if GFR is less than 30. If they have a GFR of 35 and they've been on metformin, they can continue. So do not start if GFR is less than 40. Do not continue if GFR is less than 30. Generally, what we can use in these patients is sitagliptin, linagliptin, saxagliptin. The thing about these drugs is sitagliptin requires a dose adjustment in CKD. Linagliptin, Tradjenta, doesn't require any dose adjustment. And saxagliptin worsens myocardial issues. And then GLP-1s we also stop when GFR is less than 30. It becomes an issue. So Ozempic and Trulicity and stuff like that. If you have an incidental adrenal mass, and like, chalo, you've decided that it's a benign adrenal adenoma. One thing that I just kind of like, I didn't even know this disorder exists. People with adrenal adenomas, benign ones, and you're just following them, you're going to screen them for this thing called MACE. And MACE is mineralocorticoid, autonomous mineralocorticoid excess syndrome. And what that means is they just make a little more mineralocorticoids than normal. The reason you want to screen for this is a lot of people who have adrenal adenomas have this syndrome, like 10 to 20% of people have this syndrome. And this syndrome, the presence of this syndrome in their body is an indication for adrenalectomy. Now, what is this syndrome? You will screen for autonomous mineralocorticoid excess syndrome and pheochromocytoma. And what that means is in these patients, they have more cortisol, but they have no overt hypercortisolism. So they have no Cushing features. How are you going to screen these patients? You're going to get a 1 milligram overnight dexamethasone suppression test. And if the value of cortisol is greater than 5 micrograms per ml, like the next day, if it didn't go less than 5, this is diagnostic. Often, if this test is positive, we measure ACTH, DHES, UFC, and 8 milligrams dexamethasone suppression tests to confirm this autonomous secretion. And why? Because like MACE, like autonomous mineralocorticoid excess like syndrome, kind of like sometimes indicates surgery, but just like know that like that's a disorder that exists. Okay, for evaluate, so if you're suspecting, like if some patient has like hypoglycemia, fasting hypoglycemia, you obviously suspect insulinoma, super surreptitious use and whatever. So what you're going to do is you're going to send them for a prolonged fast. You're going to be like, hey, you're not going to eat for 72 hours and you're going to get glucose every 6 hours. If glucose drops less than 60 milligrams per deciliter, that means that something funky, like wonky is going on. You're going to get 4 tests. You're going to get a C-peptide, you're going to get an insulin level, you're going to get a proinsulin level, and you're going to get a beta-hydroxybutyrate level. So beta-hydroxybutyrate is checking for ketosis, is checking if this pancreas is fucked. Proinsulin, insulin, and C-peptide. C-peptide obviously to see if he's taking sulfonylureas or if this is his endogenous insulin. Then another thing is I wanted to point out is if they're a type 2 diabetic and the urine albumin creatinine ratio is between 30 to 299, generally start an ACE or ARB because to protect their kidneys. If urine albumin creatinine ratio is greater than 300, that means they're having like microalbuminuria. Start an ACE or ARB. Or if eGFR is less than 60, start an ACE or an ARB because we want to protect their kidneys. Then another point I wanted to make is the normal TSH range increases with age. TSH generally, I forgot what the cutoff is, but like the upper limit of normal TSH, I think in the lab is 5. But just remember that in old age, TSH of up to 10 units per ml or up to 8 units per ml is kind of normal. So in old age, like the TSH can go up to 10 and go up to 8, that's fine. In pregnancy, what is the glucose target? The glucose target is 95, less than 95 fasting, less than 120 postprandial. That is different from the diabetes glucose target, which is less than 130 fasting and less than 180 2-hour postprandial. I don't remember well. But look this up. Fasting in pregnancy, we have really strict cutoffs. Another point, okay, about familial hypocalcemic hypercalciuria. Familial hypercalcemic hypocalciuria. I said that wrong. Obviously, there's an increased serum calcium. Their PTH we don't really test in these people. The urine albumin, the urinary calcium is less than 400, and the urinary calcium creatinine ratio is less than 0.01. We use the urine calcium creatinine ratio of less than 0.01 to like separate this from hyperparathyroidism. Why we check the urine in these patients is if we do a parathyroidectomy in a patient with familial hypercalcemic hypocalciuria, that's pretty useless. So remember to check urine calcium in patients because we don't know. We see a high calcium, it can either be PT like hyperparathyroidism or FHH, and then we like check the urine to figure out. Then another thing I wanted to point out is that the American Urology Association recommends that we check the PSH prior to starting testosterone replacement therapy. If the age is greater than 40, younger than 40, they don't really say anything, but like check PSA, I guess. And then we get hemoglobin every 3 months for the first year, and then we do biannually moving forward. So, okay, another point I wanted to make. Obesity decreases sex hormone binding globulin. What that means is if you're obese, you have lower sex hormone binding globulin, you have lower total testosterone in your body, and your free testosterone is normal, but your total testosterone is less, and so it looks falsely low. And so other instances where you have decreased sex hormone binding globulin is obesity, we already talked about that, insulin resistance, diabetes mellitus type 2, hypothyroidism, growth hormone excess, exogenous androgen or anabolic steroids, and nephrotic syndrome. All of these instances will have decreased sex hormone binding globulin. So obesity, insulin resistance, diabetes mellitus type 2, they all kind of go together. Hypothyroidism, growth hormone excess, exogenous androgen or anabolic steroid use, and nephrotic syndrome. These will have like a falsely low total TSH. Another instance that can increase your sex hormone binding globulin and give you a falsely elevated total testosterone is aging, hyperthyroidism, high estrogen states, liver disease, HIV, and anti-seizure medications. So just kind of know that. Then another thing is amiodarone induced thyrotoxicosis. Amiodarone is by 37% of the amiodarone molecule is iodine. So like it has a shit ton of iodine itself in it. And then also remember that amiodarone has a huge half-life. It has a 60-day half-life. So it's around for a long time. So it can cause a type 1 thyroid amio-induced thyrotoxicosis and a type 2 amio-induced thyrotoxicosis. What's type 1? Type 1 is just fancy for a Jod-Baselow phenomenon. There's an autonomous nodule. You give amiodarone, the body thinks I got a shit ton of iodine. I'm going to make a shit ton of thyroid hormone via that autonomous nodule. So the Jod-Baselow phenomena, patient with Graves or nodules, like you give them amiodarone and they go into full-blown like thyrotoxicosis. How do you treat this? You treat it with methimazole. The type 2 immune-induced thyrotoxicosis is actually a thyroiditis. Amioid just is a destructive thyroiditis. It just messes up and blows up their thyroid, and then like they have a bunch of thyroid hormone. How you treat this one is glucocorticoids. So that's kind of the reason you need to know the difference between this. If someone has primary adrenal insufficiency, just remember that you want to give them hydrocortisone. We give 2/3 of the dose, like 2/3 of the dose in the AM and 1/3 of the dose in the PM to mimic like the general like body's response to this. Remember, I think, okay, and then just remember that the incidence of pituitary microadenomas, incidentalomas is 10 to 38%. And remember that the incidence of macroadenomas is 0.2%. So it's very likely that a person, 10 to 38%, that's like almost like 1 in 4, 1 in 5, 1 in 3 people, 10 to 38% can have a microadenoma. So that's that. I'm just going to make 2 quick points. For people with diabetes type 1 and diabetes type 2, remember like to vaccinate them for hepatitis B. If they're not hepatitis B vaccinated, hepatitis B vaccinate them ASAP. The reason we're hepatitis B vaccinating diabetes type 1 and diabetes type 2 is these people are going to use a lot of needles later on. Diabetes type 1 will obviously use needles to begin with, and diabetes type 2 will also use needles because they're going to be taking insulin and shit later on. Then other 2 points, if you treat with denosumab for 3 years, it is kind of equivalent to treating for 10 years. After that, fracture rates are comparable to treatment for 10 years. So denosumab, they have to be on it for a long time, but after 3 years, they're going to gain all the benefit they're going to gain, and you can consider like bridging with bisphosphonates and discontinuing this denosumab. You don't really need to take a drug holiday with denosumab though. So just that, and then romosozumab, if you kind of want to know a little bit extra, that's like another new denosumab, and it's contraindicated if you've had a cardiovascular accident in the past year. So that's just one reason to not use it. And then remember that for insulin like for acromegaly, we do insulin like growth factor 1 testing. Okay, I'm running out of time, so I'm not going to continue. That is everything. I think this is going to be the only video for MKSAP endocrinology. I've gone over the main points, and I hope you guys have liked the video. I'm going to try to refine this format, try to make it like a podcast, like kind of how like Divine Intervention does. But for now, it's just a video, and I'm going to put up the thumbnail for like MKSAP Endocrinology. I hope you guys liked it, and thanks, and just remember me in your prayers.